trying to take it a bit further, if you try to bridge the gap in areas such as delirium or dementia in these areas, is there room for this type of research to be able to explain some of these things that are happening in the brain? I mean, because grossly we know that for inhaled anesthetics, your MAC decreases about 6% per decade after age 30. Some about down 12% where I am right now at my age. Can these things be explained and further elucidated in terms of trying to predict and treat dementia, Alzheimer's, and these other types of disease processes?
Yeah. Well, first of all, Alzheimer's disease is not my topic of research. So the EEG has been used in neurology for decades on all kinds of pathology. And of course, in fact, in some of these domains, they have evolved much further in interpretation of the EEG compared to anesthesia. But so we are just at the beginning within our research domain, how to translate this in a usable technology for our own means. And so me personally, I'm very interested in pharmacology and how to give the right dose to an individual patient. And we need some kind of measurement that tells us something of how the drugs that we give affect the brain of the patient. And we hope that then if we can control this effect in the brain, we will also have a better outcome on hemodynamics and respiratory function and so on and so on. But that's not guaranteed. And so we are just looking at this as a pharmacodynamic endpoint. And then at this stage, we focus on healthy ASA1 and 2 brains for that goal. We already have a tough job to do in that population. And all the pathology that comes on it, like vascular dementia, like all kinds of syndromal from birth, certain brain anomalies that we see in children, for example. There's to be honest, we are not focusing on that yet. We are not ready for that yet. So I can't really answer the question on the dementia because I'm not an expert, but I just want to frame it in the anesthesia context.
Yeah,
so where we are now.
For kids too, like pre, intra, and post, because these cognitive issues we see in children might be able to be explained also in the elderly as well. It's like, why are they becoming less, cognitive afterwards?
But there's a lot of information on hypotension that has an evolution or an effect on the cognitive function and so on. It's also a very new domain of research in anesthesia. But I'm convinced, and this is just basic logic, that whatever the reason is, if there's a causal relationship between our anesthesia and cognitive function in the post-op phase, how are we going to control that? The only way to control it is by individualizing our doses and give the right dose for the individual patient. And we need technology to do that. The pharmacokinetics dynamics are so complex that we can't calculate it by heart. So we need to use these computers and technology to help us to distinguish the sensitive and the resistant patient, and really to dare adjusting our dose according to these measurements. And I give anesthesia with TCI pumps, for example. Sometimes in an elderly, 1 microgram per milliliter is sufficient for general anesthesia. In some patients, in others, that's just not enough for some sedative effect. So the variability is so large, and this technology can help us to distinguish between these two groups. Vereecke.
Congratulations, Hugo, for a great presentation. My name is Erik Jensen, and congratulations for a great presentation. So my question is, it was interesting to see the resonance phenomena between the thalamus and the cortex that you showed for propofol. So that makes me think that depth of anesthesia monitors, you mentioned they should indicate the age. It might also be a good idea to input the drug being used, because as the example with propofol, it seems much more detectable in the EEG. For example, when you show the spectrogram of ketamine, that's much more difficult to find a key feature for ketamine. So I think we should maybe indicate on the monitors which drugs is being used in order to give a number of confidence on the monitor.
Yes, and indeed I'm also convinced that we need to have monitors that are adjustable to age. I think that's very clear. All the monitors use spectrogram as a basic source of information. Not all, but it's a basic way of looking at EEG. And all these, if you do not adjust for these age power differences, I think you will end up with a problematic index for certain age groups.
Thank you.
You had mentioned age as one way to titrate the propofol. How about race? I've been doing some work there. Are you planning on doing any work to see whether the spectrogram changes as a function of the patient's race, everything else being equal?
I try to be one of these scientists who is really convinced that race is a not existing difference between human beings. There is a lot of pharmacokinetic and dynamic differences between peoples that are genetically diverse, but I find race a very unclear entity. Moreover, well, the studies we've done, for example, for developing TCI models, they are probably too much directed towards a Caucasian population. That's just because the research centers were located in Europe and the US, and so that's the limit that we have to work with. And we know that, for example, in Japan, there are clusters of people that have another pharmacodynamic relationship between the drug and the effects that we measure. And of course, the better we can take this into account, the better we will be able to close the gap between both. And there is some work done because, for example, the Eleveld model, which is a propofol TCI model that has been developed for a large population with children, even neonatal children, geriatric patients, obese patients. It's a database of about 600 patients, and also it's from different parts from the world. So in that database, you would expect to see racial differences. And I have to say that this was not a significant, important factor to determine the major pharmacodynamic differences between individuals. So weight, age, whether you are a voluntary individual in a study or a patient, that makes a pharmacodynamic difference. Very important. We can't extrapolate volunteer studies to the patient population. There's a difference. But race, or which part of the world the data was collected, is not really a significant factor in that study.
We could talk about redheads as well, but we won't. Jim's.
The more complex the analysis and display of the waveform, the less likely it is to come up with a set of individual data items forming the patient state definition. That is, the eigenvalues of the measurement. That when we're collecting pictures of these and try to then go back and correlate with big data, we have nothing we can work with. It seems that the time has come to work very hard on identifying what the key features are of the EEG, collecting them in real time to allow the big data approach to come. It's a statement, but can we do that?
Yes, I can only agree with research. It starts with the small steps. And you start with searching for features in small populations with small data sets. And if you have a feature, you try to expand it to the next step. And I totally agree with that we need to continue to measure. So I completely agree. We need more data and also more neuroscientific understanding. That will help us, of course.
Hugo, one quick question. So you show the spectrogram for the different drugs and things, Have you looked at any combinations of drugs to see are they additive or synergistic or anything like that? Because they're rarely given just one
Yes,
agent.
we have, well, personally, I've just finished a large study in volunteers where we have high resolution EEG for, in several steps of propofol combined with remifentanil and sevoflurane combined with remifentanil. But Emery Brown, who has provided most of the slides that I've shown you, in fact, most of the work has been done by him, credits to him. He has done combinations of drugs. The problem is that in the US, there is not much clinical tools to titrate your drugs in a reproducible way. So his work has been done with boluses of drugs, which is on a pharmacological level not so controlled like we do with our TCI pumps. So we are working on some with opioids. We have some data, but it's still in the analytical phase. But he did also with ketamine and Dex with propofol and so on. And you can still see some features. But I have my questions on the sensitivity. If I show it to you as a blinded anesthetist with some training, if you will be able to identify this just by viewing at the spectrogram, I'm not sure whether this will be very effective. This still needs to be validated.
Thank you very much, Hugo.